The brain is a big place. I'm an anesthesiologist, so we try to make people's brains smaller. So let's see if I can get, what do I do next? Pull up my talk.
Is this your presentation that's on?
No, my presentation is right there. All right, so we're going to talk a little bit today about preclinical and clinical evaluation of autonomic function. And Beth yesterday claimed that she had the simplest slide of the autonomic nervous system to be shown at this meeting. I want to try to compete with her for that particular award. And basically what you see here is just the simplest thing I could think of. Mean arterial pressure equals cardiac output times total peripheral resistance. You see the baroreceptors up there exemplified by the carotid receptors. They're really not baroreceptors, they're mechanoreceptors. Afferent input from those baroreceptors in the aortic arch and mechanoreceptors in the heart and great vessels impinge on the brainstem cardiovascular system. When events occur which are correlated or perhaps associated with low blood pressure, they do things to evoke vagal withdrawal and an increase in heart rate. They also do things to cause an increase in sympathetic activity, to cause vasoconstriction, and the reverse occurs when these receptors are stretched. That's the world's most oversimplified view of blood pressure regulation that there is. And so the question is, why is this important? What are the ways to measure autonomic nervous system activity in humans? And for each of the 4 or 5 main ways, I'm going to talk about the ease of the measurement, whole body versus regional, temporal resolution, and whether you have to just do this while people are supine and resting, or whether you can do it during things like exercise, mental stress, other things like that, where people's sympathetic nervous system might actually be activated. And what does it mean? What do these measurements mean? How might we interpret them? So why is this important? Number one, this is some data from the Framingham study. It just shows heartbeats, or heart rate, less than 65, 66 to 73, 74, 79, so forth. And it's cardiovascular events, sudden cardiac death on the bottom, heart failure on the top. And it's just the events per 1,000 patients in 2 years. And you can see if you have a high resting heart rate, you get more heart failure and you get more sudden cardiac death. My resting heart rate's about 50, so maybe I'll live forever. Who knows? Hypertension is also a bad thing. This is also from Framingham. This is average annual incidence per 1,000 people for cardiovascular disease or stroke. You can see the different age groups. You can see that the event rates in men over here and women over there are quite low. But as blood pressure rises, things get progressively worse. And if your blood pressure's pretty high and you're pretty old, about 10% of people have an event rate or an event every year. So not a good thing. Now, why is this important? Number two, because device therapy and resistant hypertension is undergoing a renaissance here. We saw somebody yesterday, I think Dr. Zipes showed the old slides of carotid sinus stimulation from the late 60s. Things like baroreflex stimulation, renal denervation, which was tried surgically in the 40s and 30s, carotid body resection or ablation, which also has a long and interesting history, and other things are occurring to try to treat resistant hypertension. And one of the main questions that's emerged from the positive smaller trials and the failed larger trials is which patients might be candidates and which ones might benefit from these interventions. So the lineup card is heart rate and heart rate variability. We'll talk a little bit about that. Plasma norepinephrine a little bit. Talk about muscle sympathetic nerve activity, the thing I probably know the most about. Norepinephrine spillover, the thing that everybody but Steve O'Julius and Murray Esler know nothing about. And we'll talk about drugs and autonomic support of blood pressure. So heart rate and heart rate variability, easy to measure. It's linked to outcomes, as I showed in the first couple of slides. It's more than a snapshot. You can measure it continuously. In fact, there are people who live these sort of monitored lives who are in fact doing this. Excellent temporal resolution. can use just about anywhere, anytime, doing just about anything. But I would argue that it has limited information, not about parasympathetic control of heart rate, but sympathetic control of heart rate. And because it is so easy to measure, and because we all like to do math and collect data, there's a tendency for people to vastly overinterpret this, vastly overinterpret it. This sort of data, any way it can be interpreted, it has been interpreted. This is data from the early 90s, Yamamoto and Rich Usen, and this is just Ardell interval on the y-axis versus heartbeats, number of heartbeats all the way up to 8,500 heartbeats on the x-axis. So as heart rate slows, Ardell interval gets longer. They give these people propranolol, and you can see that the beat-to-beat variability does not change. Does not change when you give people propranolol, suggesting that there's not a whole lot of sympathetic control of heart rate variability. And if you convert these Ardell intervals into heart rates, the heart rate in this particular individual record went from, say, 68 to 60. So not a big resting effect and not a big effect on heart rate variability. About the same time, Karantoska and Erickson did a nice little study in the J-Physiol, and this is heart rate instead of Ardell interval, and what happens when you give atropine. Heart rate in this particular person went from about 45, maybe as high as 50, but you can see the beat-to-beat variability here. Some beats instantaneously were as low as 40, some as high as 50. You can see that heart rate went to 100, and that the heart rate variability went way, way down with atropine. Way, way down with atropine. So I think the first thing you can say from that is that heart rate at rest is primarily under parasympathetic control. All indices of heart rate variability primarily tell you about vagal control of heart rate, power spectral analysis, and all sorts of other things. Anytime anybody tells me that they can make measurements of sympathetic activity in the heart based on heart rate variability, I either run for the door or start asking antagonistic questions. If they tell me they can make measurements based on heart rate that have something to do with the sympathetic outflow to the rest of the body, then I get angry and I have a sympathetic response. So, which as people have seen over the last 24 hours, that's not hard to generate. Plasma norepinephrine, great measurement, it's linked to outcomes. Relatively easy to measure, provided you've got somebody in the clinical chemistry lab who knows how to do it. It's more than a snapshot. You can use it during exercise, but there are all sorts of issues about release versus reuptake and clearance. And this is just a single slide from a review article by Jay Kahn in one of the big trials of congestive heart failure. You look at people with various treatments here, but the point is people that had plasma norepinephrines greater than 900, after about 5 years, almost 100% of them were dead, where people that had plasma norepinephrines less than 900, only about 50% of them were dead. And that's been shown repeatedly. And it's been shown for all sorts of other cardiovascular diseases and some other sympathoexcitatory diseases as well. Now, muscle sympathetic nerve activity, it's linked to outcomes, sort of. It's higher in congestive heart failure, for example, higher in some respiratory diseases, and there's a good correlation between MSNA and these plasma norepinephrine measurements. It's hard to measure. It is a snapshot. It's hard to use during whole body exercise. It's hard to use during anything but rest. Is it generalizable? So does what happened in the muscle tell you what's happening in the heart, the brain, the kidney, whatever? And subject to subject variability is the most interesting thing, which applies to this whole topic of humans. This is how you do it. You take a tungsten microelectrode, you put it typically in a perineal nerve, but you can put it in any peripheral nerve that is close to the body. It's filtered and amplified. You get multi-unit sympathetic nerve activity. There are some newer approaches to get single units, and you can get muscle or skin. And the signal was originally thought to be noise. This is for the younger people in the audience. The people who did this, especially Aki Valbo, Carl Erik Hagbarth, and less so Gunnar Wallin, they were primarily interested in making measurements of motor unit activity in the hand. And they were motor control and sensory neurophysiologists, motor unit activity and also stretch receptors, big afferents. And they kept finding this noise. And there kept being noise in this. system, and they got more and more engineers to try to filter the noise. And they couldn't filter the noise. And then one day, and I don't know whether it was Aki or Gunnar, said, why don't we give some ganglionic blockers? What if it's sympathetic activity? And in the days in the late 60s, prior to rigorous IRBs, I think they just went and got some ganglionic blockers and gave them, and the noise went away. So this is an example of people being right for the wrong reason. They spent 2 or 3 years trying to get rid of the noise. And it turned out, if you look at the total number of papers with microneurography, the sympathetic versus the motor and afferent ones are probably about 5 to 1. So this was a good example of a lucky mistake. This is what it looks like. Here are 2 people with similar blood pressures. You can see that right on the lower part. One person has just a few bursts, the other person has a lot of bursts, but their blood pressure is the same. You can see that as blood pressure goes down, there's a burst, as blood pressure goes down, another burst, where there are clumps of bursts in the B panel as things go up and down. This is a classic slide from Krzysztof Narkiewicz when he was working with Vern Summers, and it just shows you how variable MSNA is. These are people that are normotensive males, females, less than 40 on the top 2 panels, under 40 on the bottom 2 panels. Sympathetic activity in these normotensive people can vary 5 to 10-fold. 5 to 10-fold. Same for females. As people get older, there's a weak relationship between this sympathetic activity and blood pressure, stronger in women than men, and it gets much stronger if you restrict the females to postmenopausal females. You get to actually a pretty good relationship. So the question always comes out, well, maybe it's just day-to-day variability, but if you do people, every other week, or you do people repeatedly, and you do them in the same resting conditions, the correlation coefficient between day 1 and day 2 is about 0.9 or about 0.95, so it's very high. Now, the other problem with this is that there's no obvious rise in MSNA in people with hypertension. A number of people have looked at this, and you can see that hypertensives have slightly higher resting sympathetic activity, and this is in bursts per minute or bursts per 100 heartbeats. Sometimes you do it in bursts per 100 heartbeats because every heartbeat expands or stretches the baroreceptors and temporarily suppresses sympathetic activity. And you use bursts per 100 heartbeat when you do this to account for these differences in baseline heartbeat. In general, when you do the analysis one way or the other, in most cases you don't get different conclusions, but once in a while you do if there are big differences in heart rate. And I brought this up yesterday about receiver-operator curves. This is the big problem in clinical medicine. It's a big problem with novel biomarkers. It's a big problem with gene markers. It's a big problem with markers of sympathetic activity. If you do not have a large spread between the group with events, the distribution shown in the red, and the group without events, it's very difficult to make a clinical test to guide this type of thing that Shiv and others do in the lab. It's very difficult to say, well, we think you just need treatment X versus treatment Y. When you start to get 1 or 2 standard deviation spreads between group with events, group without events, you're home free. You're home free. But for most things, you're really, talking about odds ratios of 1.2, 1.3, 1.4, 1.5, and it doesn't help you that much. Doesn't help you that much. For almost every biomarker you can imagine related to cardiovascular disease, you don't do very well. By contrast, if you take something like waist circumference, and it's much, much more predictive of these things, much more predictive, a simple measurement like that. So relationship between cardiac output and MSNA, this is something we've been doing in the lab. Individual examples, this is subject 1, had 27 bursts per 100 heartbeats. His resting cardiac output measured by acetylene rebreathing was 7.6 liters a minute. His mean arterial pressure was 98. Subject 2 had 68 bursts per 100 heartbeats, so 2.5 times the sympathetic activity, but his cardiac output was only 4.4 liters per minute, and his mean arterial pressure was 99. And so one of the things that Gunnar Nish and I have done over many years is just take this basic relationship and ask ourselves what happens in people with high versus low activity. And then we also explored some ideas, which I won't go into, about nitric oxide and how that might influence some of these responses. Here you can see muscle sympathetic nerve activity and burst per 100 heartbeats versus cardiac output. 18 healthy male subjects, blood pressure was about 95. This is with an arterial catheter. People with high nerve traffic, again on the x-axis, had higher total peripheral resistance. So people with high nerve traffic and people with low nerve traffic generate similar blood pressures through two different physiological pathways. The people down here are low vascular resistance, high cardiac output people. The people on the other side are high vascular resistance, low cardiac output people. Now, this is something we published in the late 2000s. This is a larger group. We've expanded this to about 100 in each group. You've got young men on the left, young women on the right, and there's a big sex difference. We see this relationship repeatedly between MSNA and burst per minute and TPR, and the inverse with cardiac output. No relationship in young women. No relationship in young women. When women go through menopause, they begin to look like the men. So something, and this may explain why women faint more. If you give vasoconstrictor drugs to women, they don't necessarily vasoconstrict as much, so on and so forth. We can talk about that in the discussion. So MSNA is a great measurement. It's a lot of fun. You can publish papers in high-impact journals using it, and you can have a tremendous amount of fun, but what does it mean? It's hard to do. Holly does it here, so she can tell you the existential angst associated with it. It only works in about 80% of subjects. And then after you make these measurements, the fun starts because you get to analyze them. And the analysis has gotten better because of computer programs. In the olden days, we used to have these strip chart recordings, and you'd like lay them out in the hallway and mark them. And it was, or I still have a couple to show the younger trainees, which is my version of walking uphill barefoot in the snow, both directions. And they get sick of it, Norepinephrine spillover, not really linked to outcomes. It's very hard to measure. You got to put catheters in all over the place. You do get a snapshot. You can use it during whole body exercise. The temporal resolution's a little bit low, and you can get regional versus whole body. Is it generalizable? Gunnar and Murray Esler were quite interested in this, and they looked at MSNA versus renal noradrenaline spillover. And for a whole lot of different vascular beds, they showed that there was typically a pretty good correlation. But again, you can do certain maneuvers and you can increase skin sympathetic activity, and actually muscle sympathetic activity won't change or will go down. In animal models, you can have animals weightlift. They'll start to weightlift. Nothing happens to their muscle sympathetic nerve activity. Their renal sympathetic nerve activity goes up. So there are these differential responses, which are hard to pick up. Now, autonomic supported blood pressure. This is my favorite one. It's not linked to outcomes. It's limited by the availability of drugs. There's no ganglionic blockers made anymore. I have the last supply, which I spent $20,000 one year buying up. And it's like in a safe, and I got permission from the FDA and our clinical chemist revalidated it and so forth and so on. You can't use it during whole body exercise because if people stand up when they have autonomic blockade, they fall down. It is a whole body measurement, and it might, though, but I think it might predict some response to sympatholytic therapies. So this is an even simpler version of the simple slide I showed. So basically, there are these ganglia that control sympathetic and parasympathetic outflow. There are a couple of drugs, notably trimethophan. You give the ganglionic blocking drugs, and you just ask one simple question: how much does blood pressure fall? That's it. And this is what it looks like. You got sympathetic nerve activity and blood pressure. And you can see the nerve traffic. This person had pretty high nerve traffic. You start giving the drug, the nerve traffic goes away, and you can see the blood pressure falls. This is from Pam Jones when she was working with Doug Seals. If you look at the change in norepinephrine with autonomic blockade, the more the norepinephrine changes, the more the blood pressure falls. So some people, it's a lot of fun doing these studies too, because you take somebody and their blood pressure falls 40 millimeters of mercury, and then your blood pressure rises, so the mean blood pressure in the room stays the same. And one of the good things about doing this is as a physician scientist, especially when you have some PhD translational investigators you're working with, is the physicians have to be in the room, so it forces you to leave your office and actually go to the CRC and participate in the studies. Same subject if you just look at the change in norepinephrine. And MSNA, the people with the high MSNA had the biggest fall. This is all men, younger and older men. This is what we did recently and published in Hypertension 2014 with Joe Barnes. You can see the younger women are in the dark, older women, postmenopausal, are in the right, and you can see the same type of relationship with baseline plasma norepinephrine or baseline muscle sympathetic nerve activity. So we've talked about why this is important because various markers of autonomic nervous system activity, whether they're heart rate, plasma norepinephrine, and so forth, are linked to outcomes. Diseases associated with, for lack of a better word, screwed up autonomic function are bad things, whether it's this heart rate and predictive or things like hypertension. There are various ways to measure autonomic nervous system activity in humans. The common ones are heart rate and heart rate variability, plasma norepinephrine, and sometimes epinephrine, MSNA, norepinephrine spillover, radioactive tracer techniques, and autonomic support of blood pressure. They vary in how easy they are. They vary whether they're whole body versus regional. The temporal resolution varies, and how easy they are to do, and whether you can use them at rest or during activity is important. What does it mean? I think that perhaps if we could identify who these people are, the people that have a lot of autonomic support of their blood pressure, that you could perhaps target people for various sympatholytic therapies more favorably. I have an editorial on hypertension about this. I think the renal denervation trial failed because they took kind of all comers, but if you look at some subgroup analysis and if you look at some data from Marcus Schlake and Murray Esler in Australia, they have some pretty good evidence that in people with high nerve traffic it worked. And so I think that's really the trick to figure out who it's going to work in. And then we're here, so we always have to think of John Wooden and autonomic nervous system measurements. And one of his great quotes was, don't permit what you cannot do to interfere with what you can do. And if you look at what people measure when they do their experiments, they typically follow this piece of advice, and really a lot of what is or is not done is based on their skill set, how convenient it is, how invasive it is, how time-consuming it is, and a whole lot of practical considerations like that. So that's the end of the talk, and I'm willing to take questions. Thank you.